Hi, good evening. I'm Dr. Philip McMillan, and today I'm going to be taking you through a very important case, the first case of bird flu. But I'm going to be asking some scientific questions with regards to, was this actually COVID? There's a reason for me asking that question, and it's around my own perception with regards to COVID 19. And I'll be taking you through what I consider your perception or general public perception around how COVID is viewed and where I may differ from quite a lot of people. Additionally, I'm going to take you through some slides. I'm going to take you through the report from the WHO, and I'll be trying to put the pieces together to see if I can make them make sense and put across my perspective. Now, just remember, this is my opinion that I'll be sharing. And so if you want to understand it, then please make sure you listen through to the end. Now, before we start, we'll be doing just a few reminders with regards to our chatbot. So our chatbot is a new innovation that we've come up with, and this is in collaboration with Lumientia. And what we've done is we've taken all the videos together, and so you will use the link, come to this page, put in here to get the subscribe button, which will then take you to the engine where you can search all of our videos. A typical search is something like GERT. As soon as you start typing it in, you will find that all the videos about GERT comes up. And if you're interested in, say, Dr. Shetty, and you start typing that in, you will start to see all the videos around Dr. Shetty coming up. And so it just depends on what you're interested in. And truthfully, we did this largely because we found that a lot of the content seem to be suppressed on some of the mainstream platforms. As well, there is so much content that you need to probably parse it out by using the search engine. Look in the description below for courses, the link to that Vision Med chatbot, and join us in our newsletter journey as well. So let's get back to this question. What is it that is going on with the first human case of bird flu? And I've got a BBC article here that I think will help to try and clarify what some of the controversy is about. So here in this BBC article, they highlight that a man in Mexico dies with the first human case of bird flu. He was 59 years old, and he was found to have bird flu. It's no risk to the wider public, they said. It's unclear how he got it, and he had been bedridden for weeks before getting sick with fever and shortness of breath. This is very important, and I'll be coming back to it again. Then it mentions some things with regards to bird flu generally, but the main point is that he became quite unwell with regards to this bird flu, and then he went into hospital. So I've got the WHO breakdown as to what happened, because I had a few questions that I needed to try and understand. Now, before I go any further, I'll try and clarify to you how different people look at the COVID pandemic and where I have a different view of it. So I've built this nice little slide about COVID perceptions. Some people don't even think that COVID exists. For other people, the pandemic is beyond us and we're still in that green area. For another cohort of people, they thought that it was just a flu. Some people think the pandemic is over. Some are a little bit concerned. And some are saying, oh my God, we are in some serious trouble. So you have to understand that I'm in the oh my God parameter. And that's largely because of my views around autoimmunity. Because virus is still circulating, and because the immune system has been primed across the world, you have a situation here now where people are at serious risk for autoimmune responses. That's my perception. And therefore, I am in the oh my God. So when I look at COVID, I tend to look at it from the expectation that it is going to give us trouble. So when we get back to this case with regards to the avian flu in the WHO, what we can then see is that here it was on the 23rd of May, 2024, that they highlighted that this had come out, and they published this on the 5th of June, 2024. So here is a description of the situation. I'll make it a little bit bigger so that you can see it, and make sure you can take a good look at it. So this is the case. What happened is that on the 17th of April, this person here in Mexico developed fever, shortness of breath, diarrhea, nausea, and general malaise. So look at the time frame. On the 17th of April, he developed these symptoms. He then went to hospital on the 24th of April. So this is about a week later. He sought medical attention and he was hospitalized in the National Institute of Respiratory Diseases in Mexico. He died on the same day due to complications of his condition. Now, this is very important, and this background is critical to trying to understand what was going on. Now, they then took some samples and they sent it off to the national lab, and they found influenza A virus. This then was sent for further sequencing on the 8th of May, and they indicated that it was positive for influenza A H5N2. And this was not a typical influenza virus that they would normally see. So it was at this point that they realized that this case of H5N2 was not typical of what you would expect with regards to normal influenza virus. This is where the bird flu question came from. Now, there are a few points about this that are very important, and I'll take you through the clinical steps in just a minute. But before I do that, I'm going to explain to you from a scientific point of view where it is and what it is that I am looking for and why I look at it in a particular way. So let's get back to the basics. So we have here an image showing an upper airway infection. And what it has in the image here, this is the virus. The virus then goes into the upper airway and it infects the nose and the nasopharynx, and then it can spread out and down into the lungs. This black mark with these Y-shaped images are to represent antibodies, mucosal antibodies. And the purpose of this is to highlight that in the majority of cases, the virus cannot penetrate this mucosal barrier. And so therefore, it doesn't get into the systemic circulation. These are lymph nodes, which would then make lots of antibodies. And so there is a separation of the immune systems. So that's the first point, is that the virus has to first get past mucosal immunity before it triggers a systemic response. This is where we normally do the testing from. So this represents a nasal swab. It's a straight swab, and so therefore it can't get up here. And this is where you can also get the virus infection. It goes straight to the back, and primarily it takes the samples from the nasopharyngeal or epipharyngeal region. And this is where the adenoids are in children, where they take it out. In adults, this tends to disappear. But this is where the swab is usually taken from. And so they're measuring viral titers here when they're looking for virus, SARS-CoV-2 or even flu. In SARS-CoV-2, you have a progression of infection from the healthy lung going down to infected lung. Then we have the microclotting with viral pneumonia, then very severe viral pneumonia. That was the typical presentation of COVID. It doesn't happen as frequently because people either have natural immunity or hybrid immunity, where they're infected and vaccinated. Because at this point, I think everyone has been exposed to at least the Omicron virus. This is very important, and this is going to link to what I'm talking about with this gentleman. And so I've got here a timeline in days, 0, 4, 8, 12, 16, 20, 24, 28, 32 days. And I've got here SARS-CoV-2 viral load. Also, it would mean the flu viral load. And I've got a time frame where blue represents, in my mind, the mucosal SARS-CoV-2 viral load. The red represents the serum viral load, and the black represents the mucosal, upper airway again, flu viral load. And I've put this together to show you what I am thinking occurred with this gentleman, and I'll take you through the steps as to why I think so. The point at which he would have presented to hospital would have been about here. And this is what I describe as the viral sepsis. Now, this is an important sequence of stuff, and it's based on the fact that I look carefully, generally, at patients to make sure they fit in the box. What that means is if somebody's got a chest infection, I expect certain parameters to be occurring. Now, it doesn't happen in everybody, but in the vast proportion of patients, if you've got a particular condition, it's associated with specific symptoms. That's how, from a clinical point of view, we work out what's happening with patients. Now, some patients don't fit in the box, but they're usually the exception. And so my rule is, unless this is an exceptional case, I would expect the patient to fit in the box. So let's take it back to what happened with the WHO. So here we have in this here, and let's just make it a little bit bigger so you can see it. So on the 17th of April, this person, he was 59 years old, and I think he probably had obesity, was obese with type 2 diabetes, but it suggests that he was generally okay. But look carefully at this here. The case's relatives reported that he had already been bedridden for 3 weeks for other reasons prior to the onset of the acute symptoms. This suggests that he was unwell. And this is the trajectory that I would tend to see in patients. They don't realize that there is now a significant delay between the onset and the exposure of SARS-CoV-2 to becoming quite unwell. So 3 weeks before, he is unwell for no particular reason for which he is in bed and fatigued. No clear thing. And I guarantee, well, not guarantee, but I suspect if you quiz the relatives, he had a cough probably at this time, just wasn't feeling well, was in bed. Then he deteriorates on the 17th of April. So this is 3 weeks afterwards. No, well, actually about 2 weeks afterwards. Now he gets fever, shortness of breath, diarrhea, nausea, and more malaise. So he's feeling even more unwell at this point. But he was able to manage at home, and his family could take care of him at home. But clearly by the 24th of April, he was too unwell. I would have been interested to know whether or not, when he sought medical attention, whether or not this was with paramedics or paramedics brought in. Now, here is one of the very interesting things, and this is a clinical point. What I tend to look at is the degree of hypoxia that somebody has. So what we have been seeing generally with patients, and it is not explained properly, is that people, when they are coming into hospital, sometimes have remarkably low levels of oxygen saturations. Just so that you understand, normally in somebody who is fit and well, we expect your oxygen saturations to be between 94 to 100%. That means how much oxygen is in your blood. For somebody who has COPD, you would accept about 92 to 94%. For people who have quite severe COPD, you would tolerate 88 to 92%. Rarely in the past, before COVID, would you see a patient coming into hospital with oxygen saturations of 80%. If you saw that in a patient, they would be just about to arrest. They would be going to die. But since COVID, we have seen a very unusual pattern where people can have oxygen saturations all the way down to 60 or 70% and still be talking to you. It's what we call the happy hypoxia. But even beyond severe COVID-19, this pattern still exists. So my question would have been, when he first presented and they called, or when they tried to take him into hospital, what were his oxygen saturations on room air? Now, if his oxygen saturations were, as I predict, to be less than even 90% for somebody who doesn't have underlying lung disease, that is suggestive of happy hypoxia. We have never seen it before COVID-19, and it seems to be related to the immune response rather than the viral response. And so that would suggest that he was in the viral phase of the disease. This is why I usually want people to publish not just sound bites. I want them to give me details. I want to know exactly what his oxygen saturations were, what were his blood gases, what was his blood pressure, what was his temperature. Give us the details. Let us analyze the data. Don't tell me that it was influenza, because based on the trajectory, I would suspect this could be quite significantly something else. So let's get back to my images just to show you what it is that I'm looking for. So I picked this here to try and show the time frames. If I was right, 3 weeks before he presented to hospital, he would have had an infection with SARS-CoV-2. This would have made him very unwell. But you will notice that the viral load in the mucosa will fall down pretty quickly. By about 8 to 12 days, it will drop down to probably not so significant. So if you haven't tested him in this phase, you wouldn't get a positive test, because one of the things that was shown there is that he was negative for SARS-CoV-2. So I'll go back to that in a minute. However, one of the other things that we have is the fact that if he then had what I describe as viral sepsis, where the virus is now circulating in the bloodstream, it doesn't mean that he would still be positive in terms of his mucosal test. And if you haven't done a test on the viral load in the bloodstream, you will have no idea. This is a really, really important point, because without that understanding, you could miss an absolutely critical phase of the disease. The reason I'm highlighting this is because I am anticipating that this trajectory is going to continue. This is not a one-off. And then people will potentially inappropriately label this as influenza. Now, that may be convenient for some people who are trying to put the SARS-CoV-2 issue behind them, but it doesn't help the clinical situation in trying to work out what is going on. So when we look back to the WHO report, what we have here is that we can see that they did go looking for other things. So he was tested. Other family members were tested. They sent it off to the Mexican National Influenza Center, and they found that it was the H5N2. But he had 12 additional contacts. 7 were symptomatic, and 5 were asymptomatic that were identified near the case's residence. They tested all of them, and all 12 samples were negative for SARS-CoV-2, influenza A and B. So it seems as though it came out of the blue. That's again very important. Again, as I say, there is a delay if you do the testing at the wrong time. And critically, Omicron tends to preferentially infect the sinuses. And so very often patients could be negative today and positive a few days later, because most of the infectious viral particles are located in the sinuses. That's just a unique characteristic about Omicron versus some of the other variants that existed before. Now, here is where we get into what it is that I am looking for. And this is why I would have wanted a serum sample looking for viral load and viral septicemia. Here is the piece of the puzzle that I think is very relevant. When we look at this here, and this is my work on the COVID immune team, and this is part of the COVID 360 advanced course. This represents all of the main cells that are involved: monocytes, neutrophils. These are the lymphocytes. These are the mast cells. One of the characteristics with regards to persistent infection with SARS-CoV-2 is that it enters these cells, and it technically makes them non-functional. So this is why we will see in a lot of patients lymphopenia. And lymphopenia is not, it can occur in quite a few viral infections, but it is very significant in COVID and it can be quite persistent. But if you have this taken out of the picture, what you then can occur is that that person, through a number of different mechanisms, poor immunity, interferon suppression, they become vulnerable to many other viral infections. And so even any flu virus that is around could then infect the person and they would struggle to clear it. This is my suspicion in this case. He did have flu, but flu was probably not the cause of death. And again, I'll explain to you why I say that. I'll take you back to the WHO details on this. When we look carefully at what they said here, on the 17th of April, as I said, he had the fever, shortness of breath, diarrhea, nausea, and general malaise. On the 24th, he comes to hospital, which is a major respiratory diseases hospital. He died on the same day. Now, let me explain something very important with this. If he died on the same day that he was seen in a major hospital, that would have meant a 59-year-old with no other significant comorbidities who deteriorates unless he died before he reached the hospital. But if he reached the hospital, even if he was very sick, he would almost certainly have been referred to intensive care. So the intensive care would have come to see him, they would have intubated him, and they would have ventilated him. If this is a flu, I would think that you would certainly not expect him to die, even though it is possible, within 24 hours. On the other hand, if it is COVID with microclots, he could, even with intubation and ventilation. And that's the critical differentiation. And so what I need and what scientists should be getting and what clinicians should be asking for across the world is the exact details as to what happened in this case. I want to know exactly how he presented. I want to know what steps were taken. What did he respond to? Why did he not respond? What was the exact cause of death? Was it a cardiac arrest? Was it an arrhythmia? Was it a clot on the lungs? Then we need detailed autopsy data. I want to see what was happening in his lungs. I want to see whether or not he had microclotting. If he did, this is very characteristic that it could be COVID-19. On the other hand, did he have viral dissemination like what we saw in previous autopsies? This is where details matter, not sound bites, not impressions, not opinions. Give us the details. Let us analyze it. Let us look at it. Let us then make the judgment ourselves. That's the clinical approach to medicine. And that's what we need at this point. Based on the predictions of Gert, he anticipated that by the end of June, this COVID is going to kick off in a serious way. I think the time frame is always problematic. I think that what we'll be seeing is more and more cases of viral sepsis. If clinicians don't know that this is what they're dealing with, viral sepsis around SARS-CoV-2, we can't then come up with ideas as to how to manage it. Patients will die. Lots of patients will die. Even if we understand it, it doesn't mean we can fix it. But this is a very serious trajectory. I don't want politics to get caught up within this. I don't want people to label things as bird flu for the sake of giving out other issues that can cause problems. We need to know exactly what is going on. We need to know why people are vulnerable and exactly what is happening. That's what we need at this point. I'd appeal to those public health agencies, WHO and so on, give us the facts, give us the details, let us analyze it. Don't tell us what the answer is until we have seen the autopsies. That's when we'll make a judgment. Again, thank you for listening. Remember to look at our Vision Chatbot beta, and if you want to join on the advanced course, there will be a description or there will be a link in the description below. Have a great evening.